Good morning. Good morning. Okay. Well, we are incredibly excited to welcome Dr. Chris Gonzalez, and I'm going to tell you a little bit about Dr. Gonzalez in a moment. But first, I want to introduce our lectureship, the Jack W. McAninch lectureship. This was an endowment created under Dr. Carroll's leadership, and is a special one. Usually endowments are created by patients. This one was actually created by the faculty and all of Jack's former fellows. Peter likes to point out that he's actually the original Jack McAninch fellow, since he was out at the county, and Jack is Peter's mentor. Well, Jack has been an incredible mentor to me, and he's family, and it's a really special day. Jack is a special person, and I love this day because we get to bring luminaries from across the globe here to UCSF to talk about reconstructive urology. Dr. Gonzalez fits the bill. Dr. Gonzalez was a linebacker at Denison University in Ohio before going on to Iowa for medical school. He was then a resident at Northwestern and joined the faculty there while serving a 10-year run in the National Guard, U.S. Army, reaching the level of captain, honorable discharge. At Northwestern, he led the VA for a period of time and was also the director of the operating room at the main hospital. He also earned an MBA from Kellogg. He then went on and was the Lester Persky Professor and Chair at the Urologic Institute of Case Western for a period of time before, in 2018, going to Loyola, where he currently serves as the Albert J. Jr. and Claire R. Speff Professor and Chair of Urology. He has done so much in organized urology and made many contributions to the AUA. Many noteworthy things, including being the chair of the AUA Public Policy and Practice Management Committee, being a vice chair of the Quality and Science Committee. He's been a longstanding member of the ABU Exam Committee, and now is a American Board of Urology trustee and directs the operations of the oral boards. So for those junior faculty that are going to take that, you can get some inside dirt from Dr. Gonzalez about what's going to be on there. So in addition to being an incredible leader, which I can attest that he is, he's also a formidable academic. He has over 150 publications in reconstructive urology, and has brought some really creative thinking to our field. And he's an incredible teacher, but I can attest he's a mentor. He's been a mentor to me. The typical phenotype for a chair in urology is an oncologist, and he is not similar to me. And he's been in my corner for a long time. So I'm just really grateful that he's here today to share his wisdom. So Chris, come on up.
Good morning. It's great to be here. This is just a fantastic department, very historic department, and lots of good things come out of here. So I think all the residents and trainees should be very proud you're coming from here. And just talking to Peace on the way here, he got a little bit of the scoop of what's going on. So I'm going to talk about management of adults with failed pediatric hypospadias repair, but we'll talk about a couple other things first. So there's my disclosures. I speak for myself. So Dr. McAninch, I never trained with him, but just always knew who he was. Always was just an incredible individual. I'll give you a little anecdote. There was a clinical society of GU surgeons meeting at Northwestern in the year 2000. I know you don't remember this, but I remember it. My wife remembers it. And just starting out, and he did not have to be nice, didn't have to say. He sat down with my wife and I, we had dinner together, learned about animal husbandry, which I thought was very interesting, but was just a very pleasant individual. And, I think that just speaks a little bit to just the individual that he is. I think that not many people have really there's a lot of people that do a lot of productive things in urology, but who really turns the dial, who really makes things happen that is going to last with the field for a while? And that's Dr. McAninch. He's really done that. And just really incredible. I mean, I've seen him get so many different awards, but it seems to me that his biggest gift is going to be his legacy of people who got to know him. And I'll give another talk a little bit later about somebody else like that, a guy named Jack Grayhack, who was a very similar individual who just the legacy was people, just the impression he left on people, the influence he left on people. And I think that that's one of the most important things. So congratulations, Dr. McAninch. This is very well deserved. So let's talk a little bit about Loyola University, Chicago, where I come from. So Lakeside campus there, it's about 17,000 students, 11,000 are undergrads, about 6,000 are going to be graduates. And there's a campus, a sister city campus in Rome, Italy, actually, that they have. So it's pretty nice. Do a semester abroad. D1 sports program. They made it to the Final Four in 2018. They actually won the basketball tournament in 1963, which is the only team from Illinois to do that, which is pretty impressive, actually. 2 volleyball championships on top of it as well, too. So they actually are somewhat competitive. So if you look at Chicagoland, you can see that on the lakeshore is going to be where pretty much all the Loyola University is. However, we're located in Maywood. So the question is, why is that? Why are we located in Maywood so far away? Well, there's a story behind that. So this is an infirmary around 1918 in Hines, Illinois. So Hines, Illinois was part of Maywood. So what happened is that Edward Hines Sr. was a big lumberman back in Chicago back in the day. His family actually still does have a lumber company that still exists. So his son, Edward Hines Jr., went to World War I and died, killed in action. So the dad wanted to do something. So the government was looking for a place to house all these veterans after World War I that needed help. So they're thinking about the Field Museum in Chicago as clearing it out and making it an infirmary. He stepped up and said, here's 300 some odd acres out of Maywood. I want you to call it Hines, Illinois, after my son. And I'm going to give you $1.6 million on top of it, which is the equivalent of about $39 million. So they built the infirmary. President Harding was involved in the whole thing, and it worked out well. There was no VA system at that time. So as the 1930s rolled around, the VA system was created, and they turned us into the Edward Hines Jr. after his son, VA. It's still called Hines, Illinois to this day, which is kind of interesting. So the Hines VA is the 6th largest VA in the United States. We got about a 600-bed hospital there, a lot of outpatient clinics. So it's actually a pretty busy VA. It's just within walking distance of Loyola. So how did the VA get to Loyola University Medical Center? Well, in 1962, John F. Kennedy was the president. Good Catholic guy, knew about the situation that Loyola had their medical school in the city, but they wanted a bigger campus. So he did something called a quitclaim deed, which is basically just saying, we're going to give you 60 acres to build your campus on. We're going to charge you $1 to do this. So that's where Loyola University Medical Center came from. And the medical school actually is founded on this area as well, too. So medical school does pretty well. They get about 12,000 applications a year, about 170 students. The medical center is about a 600-bed medical center. Burn Center, we do about 20,000 cases that run through there every year. So it remains very busy. And we sit just on the outside of the west side of Chicago. So again, lots going on. Now we're part of the medical school. The university sold the medical school, sold the medical care complex to Trinity Hospital. So we're part of Trinity Healthcare, which in and of itself is the 5th or 6th largest healthcare system in the United States. But you can imagine it's 88 community hospitals and 1 academic center, which is us. So you can imagine the challenges associated with that, right? So there's some opportunity, there's also some challenges. But again, it's a $33 billion organization. So we want to buy equipment and things like that. We got to work with our own medical center leadership. We also have to work with the Trinity Medical leadership, which sometimes doesn't understand the medical mission or the university academic mission, even after 12 years. So we're still working on doing that. But anyways, it works for us, and we continue to grow. So if you look at the University Medical Center, here we are in Maywood. That's the Stritch School of Medicine, the Hines VA, and the Loyola Outpatient Center. Then you got Gottlieb Medical Center, which is in Melrose Park. It's about 300 beds. not too far away, about a 10, 15-minute drive. Then you got McNeil, which is in Berwyn, and these were purchased probably within the last 10 years, which is, again, about a 350-bed hospital. You've got Burr Ridge, which is down here, a pretty affluent suburb in the western area of Chicago. And we have a big box outpatient center there. And then Tinley Park's going to be down here on the floor, way down here by I-80. So basically, that's another area where we do radiation treatment, and we have outpatient services there. So again, we're trying to grow, but the question is do you want to buy hospitals, or is it going to be more outpatient? And I think that's a big struggle right now, trying to figure out what to do with that. So Department of Urology, 105th year of a training program since 1919. We've got 17 full-time faculty at LUHS, the University Health Service, or the VA. 3 half-time pediatric urologists that spend their time between Lurie, and then the other half-time is going to be with us out in the suburbs. Urogynecologists, we've got 3, 5 APPs, and we've got 18 residents, a 6-year program, 5 fellows. You can see SUO, FPRMS, GRS, and endourology. So we're pretty busy. And we've been trying to hold on to that protected year of research. Do you guys still have that protected year of research here? Yeah, so that can be challenging. So pediatric hypospadias. So hypospadias is seen in about 1 to 250, 300 live births in the US. It's the most common congenital penile abnormality. Cryptorchid is the most common abnormality that we see, but the most common penile is going to be pediatric hypospadias. Pediatric hypospadia surgery, about 90% success rate reported. Over 200 different repairs. So this has really been vetted as far as what people are doing out there. Complications range anywhere from 4 to 32%. But the bottom line is that people do, our children do quite well when they have this done. But the question is, are we operating on all the people we need to be operating on? Or are we operating on too many of these folks? So again, what happens to them is they got a good success rate, but then they kind of disappear, fall off the radar. So the range of complications into adulthood and after childhood hypospadias repair remains poorly defined. So again, we're having a hard time tracking them. We try and we went to a place, we went to Sweden with the Northwestern Department of Urology a few years ago, and found that they have a database that tracks all 8 or 9 million people that live in the country. But they still had a hard time tracking what happens to these folks. And some anecdotes are, we got an IRB when I was at Lurie as a resident. Let's call these folks and see how they're doing 20 years later. That was probably one of the worst ideas ever. You get on the phone, hello, well, yeah, he moved to Seattle or he moved to wherever. He doesn't live in Chicago anymore. And the other problem was, what are you talking about? I didn't have surgery as a child. Nobody ever told them they had surgery as a child. And the other one is like, who gave you my number? I mean, it was terrible. So we had to shut it down. I was on the receiving end of some real serious, who are you and what are you doing? So that wasn't a very good idea. But anyway, so you got to be, it's very delicate, actually, is what I'm trying to say. So complications to adulthood it's a very challenging cohort to treat. And I will say, I took care of a lot of these folks in Northwestern. I'm taking care of a lot of them in Loyola. They find you. They've got their chat sites. They're on the internet all the time. And you get really close with these folks. They've got significant issues. So a heterogeneous disease spectrum. Urethral stricture is going to be one of the most common things that occurs with diverticulum, fistula, hair, severe LUTs, sexual dysfunction. The non-urethral complications also make it even worse with glands deformities, trapped penis, persistent curvature, and ED. So there's a real full bag of issues when they come see you. The biggest thing too is psychological distress, social embarrassment. A lot of these guys are in their 30s. They come in with mom's still around, trying to help them, escort them through the system. It's challenging. So meta-analyses show that, pretty high number of these guys are dissatisfied with the appearance of their penis after they've had pediatric proximal hypospadias repair, but even after distal hypospadias repair, they have problems. Another study showed that nearly 75% of adolescents and adult men felt they had not received adequate guidance or didn't even know they had surgery. So sometimes the parents keep them in the dark. Sometimes they will tell them, hey, there's an issue, don't worry about it. But when they have problems, they're embarrassed, they don't want to come to the doctor, and they'll get dilated and they wind up having 25 or 30 manipulations by the time they see you. So when you see them in the practice, when you see them in the clinic, what kind of surgeries did they have? That's the first thing to think about, trying to get that down. You're never going to find out how many they had, but it's going to be in the 20s, 30s. I had this done, Dr. So-and-so did this. I can find out who their pediatric urologist was. It was Casey Furlet, it was Lowell King, all those types of things, but that's about the only thing I can find. What did he do for you? Well, he did some really good work on me. But this happened and that happened. So and then the local urologist, the community urologist will send them to you. Penile urethral anatomy. So where's the original hypospadias Located, the penile shaft size. Many of these guys have smaller penile shafts. Is there concealment, which a lot of them will have concealment as well? What's the skin integrity and scarring? Do they have lichen sclerosis? Urethral stricture length and location? How much LUTs do they have and how much bother do they have from those lower urinary tract symptoms? And then sexual function, core D and curvature. So a lot of times we'll have them bring a picture in of what their erection looks like, or we can give them a test dose of a prostaglandin in the office. So again, that's something important to keep in mind. But the biggest thing is when you're thinking about treating them and what they're looking for is what are the patient preferences and expectations? That's the number one thing. What you think might be good for them might not be something they're looking for. So I think it's very important to understand what were the goals of treatment. So Dan Stein, back about 10 years ago, one of our residents did some nice work where we got a couple study groups of about 10 guys like this each, put them in a room. None of us were around, got them some pizza, turned on the tape recorder and said, just go, just talk. What do you guys think? So the size of the box represents the amount of time in the conversation that was spent. And you can see a lot of the things, a lot of the myths that we think as physicians are important, really weren't important to them. And some things that I wasn't thinking about really were important to them. So you think about location of the meatus, like we're obsessed with, we got to get that thing built up in the coronal sulcus, up in the glands, and not that big of a deal for at least these guys, but you look at early embarrassment, resilience, post-operative, what's going to happen to me, embarrassment, all these different types of things. I thought that was very interesting. Sit to void. So we make a big deal. I'm going to get you to stand to pee. I've been sitting the last 20 years. I don't need to stand. I can sit to pee. So again, that's something that's very, very important, not very important to them as well. And cosmesis. So you would think we're going to make it look real pretty for you. Well, yeah, just get me going again, doc. I really don't care what it looks like, So again, but some people may come in and say the opposite. They may say, it's really important what it looks like to me. So again, a lot of it just depends on what we're looking for. And I think it's important to really check in with the patient and understand what the goals of treatment are and individualize the treatment for these folks. So here's some comments that we got from that. I know I can pee standing up. I prefer to sit down and catch up on my reading. It's in the back of your head all the times. When you're self-conscious, you kind of shy away from things. When you have something like this at a stage in your life when you're starting to develop and starting to become, basically move from a child to a man, it sort of kind of screws with you mentally. So you can just feel the pain, when you hear these, when you see these comments that are made. And there's actual comments that we took from these folks. So again, thinking about what's important to them is like extremely, extremely paramount when you're thinking about coming up with a treatment plan. So management. So minimally invasive options. I think they've already gotten it. That's why they're coming to you. You just put them on CIC and call it a day. You should talk about it, but I don't think that's really a good option for some of these guys. Most of them are going to be pretty young in their 20s and 30s. There's urethral reconstruction. I want to spend a little bit of time on peritoneal urethrostomy. Know that in the stricture guidelines, we updated this, that surgeons should offer a peritoneal urethrostomy to anyone who's had a high risk of failure of urethral reconstruction. Well, these guys are like right at the top of the list for high risk of failing. So peritoneal urethrostomy at first glance may seem like, what are you doing to me? I don't understand this. But if you talk through it, sometimes it might make a little bit of sense to them. So I think it's something at least to keep on the plate when you're thinking about a treatment plan. So again, they're going to do their reading on the internet too and come in with a stack of papers saying, well, it's just a consideration for old men, salvage procedure. What about my sexual function or fertility? What's the appearance going to look like? I'm going to have to sit to void. We talked a little bit about that. Am I going to get infected? Those are the kind of questions that you have to be prepared to answer. And if you can answer those and make them feel that this might be a viable option, it might be a one and done, as we tell them, versus maybe another staged operation, they may consider it. So historic success rates are pretty good, 72 to 100%. Kulkarni and Barbagli, one of their classic studies, good solution for extensive disease, treatment fatigue, good quality of life, and patency rates. Those are all true. But again, there is a learning curve on this as well. I think some of the studies here from Jeremy Myers and Dr. McAninch is, I think the biggest key of this whole thing is preservation of the dorsal plate and longitudinal blood supply. Extremely important not to transect that urethra if you can avoid it. And by keeping that blood supply, I think that's what's going to, no matter what technique you do, I think that's going to keep you in the ballgame of making this thing last a little bit longer. So we've really gone to the inverted U-flap technique. Some people call it the Blandy technique, who described it. But again, if you look at a contemporary series of like over 100 men, the success rate is about 50% at 71 months. Now, what's interesting is that that's the front end of the success rate. The back end is they've probably got a 25% failure right now. They got better at doing it over the past 8 years. So I think that's important to know. There was a learning curve, but again, must set the expectation regarding the outcomes. This is not going to be 100%. You could have a recurrence. You may have to redo this one over again as well too. So something to keep in mind. Here's a schematic of what it looks like. So I think you guys have all probably seen this, but the inverted flap. The biggest thing is when you got morbidly obese patients, you've really got to measure this flap up perfectly. If you don't, you're going to be reaching, you're not going to be able to get it there. So sometimes that U is going to be coming all the way up to the top part of the scrotum, so you can get that thing to go all the way down. And we've got some pretty big people out in Chicagoland that will come by. So we have to kind of figure that out. But again, keeping the blood supply intact with the urethra, opening it up. So in the inferior aspect of that, or the superior aspect of that flap, right down to the inferior aspect of the urethrotomy, and then bringing the scrotum down and then just closing it up. So just a picture of what we've done, just kind of setting it up. But you want to keep that flap nice and thick. You don't want to get it too thin because it can have problems if it is. And obviously, we're just kind of starting to bring it up there and bring the scrotum down here. So this is a case just to kind of demonstrate the inverted U technique and how durable it is. This is a young 12-year-old boy, not anything to do with hypospadias, but we've got missionaries, and the Jesuits do, and Loyola across the world that sometimes will send us cases. And this is a poor individual who was abused. He basically had his penis and his scrotum and testicles cut off. And they brought the urethra out, we think, and here's a scar right here. So the question is, what do you do with him? He just had a little fistula here. He was voiding out of him, straining, and was not emptying his bladder very well. But again, I think this inverted U flap was pretty good. I mean, you could still make the inverted U flap, make it thick. It had good blood supply, came together pretty nicely, and it was pretty durable. It worked pretty well for him. So again, I think even if it's a redo case or something along those lines, it's something that is very durable and something you can consider using. So again, however you do it, just as long as you're consistent with how you do it, keeping the urethra intact is the most important thing. But again, I think this is probably the way to go, at least with perineal urethrostomy. So a few case presentations, just to kind of understand a little bit about these individuals. So one was a 17-year-old male presented with severe frequency and urgency, three UTIs in the past, fantastic baseball player from the northern suburbs, history of 3 operations on his penis as a child. He told he's urinating from his scrotum initially, had good AM erections. I always want to ask him about that. Stenotic meatus, no palpable plaques or induration of the shaft. Scrotum was normal. Everything else looked good. There's a picture. So you can tell a lot from this. So what are some of the things you can tell? Where do you think the original hypospadias was? Right? So probably right there, it said he was voiding from his scrotum. So this most likely is probably a penile urethral stricture, because usually you start at where the original hypospadias was and say the stricture is probably going to be about that long. That's usually what it's going to be. But he's got good skin, and there's probably a decent chance that you might be able to do this in one operation. But again, that's going to be something you have to discuss with the patient. And here's a retrograde urethrogram, kind of proving that point. For our students, do you guys know what this is? What it's called? It's called a Brodny clamp. Used to do retrograde urethrogram. Is anybody still using that here? I know Dr. McAninch knows about it. Yeah, not used very much. It's not bad though. It keeps your hands out of the fluoro, out of the radiation. You put it on, you shoot the rug. And so might not be such a bad thing. But I'm gonna have to go up to the museum in our hospital to go grab it out of there. But it might not be something to consider. How about another one? 23-year-old male with a history of hypospadias repair at 2 years of age, subsequent surgery to address weak urinary stream. He developed 2 streams. Now just has 1, which comes from his scrotum. He lives with his parents, rarely leaves the house, spends all the time in the basement playing video games, unfortunately. He's depressed. On exam, his penis is concealed. A large defect of the penis scrotal junction, his urethral meatus is constricted. And again, he's got numerous white blood cells in his UA when he sees you. And you see that, right? So he knew he had it, doesn't want to come see the doctor. The poor guy is a wreck, psychosocially. So this is another classic situation of this is probably not going to be somebody who's going to get 1 operation. It's going to be multiple operations if you want to restore his urethral continuity, or he could be a perineal urethrostomy candidate. But again, he's in his early 20s, as I remember. So how about another one? 33-year-old male with a history of several surgeries for his penis as a child. 4 years ago, he developed post-void dribbling in a weak stream. 3 UTIs in the past year, not sexually active, occasional AM erections. Anxiety, you see this is a running theme. Depression, urethral meatus is patent, palpable mass in the ventral aspect of his penis. So what does that make you think of? PVR at 250, so he's got an infection. So he's got obstruction. If you take a look at him, what do you see there? That little lump right there. So that lump most likely is going to be that, right? It's going to be a diverticulum with a stricture right behind it. So again, pretty difficult. This area in here was not so bad, but right in here, there's a real issue. So obviously he's going to need some work as well. So when you think about a single operation, just trying to fix these, you have relatively healthy skin, that's check. Short segment pathology of a stricture or diverticulum, check, you can do that, right? A small fistula, yes. Distal revision, glandular or subcoronal, I think you can consider that, right? Most people don't fall into that category. Most are gonna be a little bit more complex. They're gonna have lichen sclerosis, lengthy strictures, diverticulum, presence of hair in the urethra. The architecture of the penile shaft is distorted. That's a big thing to keep in mind. If it's distorted, you got a lot of things going on, they're probably gonna need a multi-stage repair. Severe chordae scarring with erections. So that's something you want to take care of if you're gonna do it in a multi-stage approach, and probably most likely on the first operation that you do. And that's usually what we do is in the first stage. So just going through some data, there's a lot of data out there, but they're small series, retrospective. They pretty much tell the same story. You know, I go back to some of the classic papers by Dr. Barbagli. Good success with single stage, but it's patient selection is the most important thing here. It's not so much that this operation worked because of the operation, it's because of the patient selection that it actually worked. So again, his were penile skin grafts and buccal mucosa grafts had equivalent outcomes, so no lichen sclerosis. He did direct closure of pretty simple things like fistulae and meatoplasty. Now, some people will go all the way and use pedicle flaps for the penile skin, and certainly if the patient has the tissue to do it, so be it. But there's also studies saying you shouldn't use a pedicle flap. You should probably use a graft onlay if you're going to do it in one operation. So again, jury's out a little bit on that, and a lot of it depends on your experience as the surgeon and also the patient, what the patient wants and what the patient is presenting you with as far as the health of the skin and the presence of lichen sclerosis. So again, caution, but if you got the experience to do that, then so be it. But you can see, even in the best of hands, the failure rate was nearly 50% at 10 years. Penile strictures are hard to work on, even if you don't have hypospadias, right? You have a really high risk of complications, and also most likely a failure coming in about 5 or 10 years. So multi-staged, again, similar story. The thing about this is that use buccal mucosa if you're going to do multi-staged. I think that's the underlying, when you look at all the studies that are out there, avoiding lichen sclerosis and also just the durability of the buccal mucosa, I think, over penile skin. I think the penile skin on these hypospadias has already been moved around, been devascularized. I mean, so it's pretty, you just look at it, you can tell it's probably not the best thing to use. When you look at all the different types of urethroplasties, when Dr. Barbagli did this, stage procedures had the highest predictor of treatment failure, the worst of the worst. So really, you're really pushing it out there for these patients, but you got to let them know that, hey, this is where I'm going to put you together, but there is a risk of complication. There's also a risk of this thing coming back. I think so long as they know that, they can make the best decision they can versus a perineal urethrostomy or something along those lines. Chris Morrison at Northwestern, when we were there, took a look at our experience over 14 years, found similar things. Don't use skin, use buccal mucosa. Most of the pathology was penile urethral stricture involvement. I stage all these guys. And I think that's, 81%, at least what they told us that they were still functioning. Did we scope them all? We did not. We talked to them on the phone, so that is a significant weakness of the study, but they said they were peeing fine, had no problems. Whether that's the case or not, I don't know. So we did publish this, but again, stay away from skin and use buccal mucosa, I think is the theme here. So there's a ghastly picture right there of taking buccal mucosa. You can get about 6 or 7 centimeters on each side of the cheek. What's the one thing you want to look out for when you're doing your dissection? You guys all know that, right? So what happens if you hit Stenson's duct when you're doing it? You call the ENT, or what do you do? Probably not a whole lot. I mean, it's just going to fistularize back in, just as long as you don't use cautery on the area. And you shouldn't use cautery in the mouth, I can tell you from my administrator position, because it causes fires as well too, right? So you got to be careful about that. With the oxygen, with the prep and everything else, it's like a perfect medium for a fire. So we have had those happen, not us, but in the ENT realm. So anyways, you can get about 16, 17 centimeters. You guys take lingual tissue? No, we don't either. And lower lip, we stay away from that because of the paresthesias that it can cause. So you're a little bit limited on how much you can take. So we do take some skin on occasion in addition to this to augment what we're taking from a graft perspective. If we do take skin, this area is usually pretty hairless down here. We'll take it. It doesn't hurt the patient. They're perfectly fine with it. it's going to be right around the belt line on either the left or right side. So they're okay parting with that. Sometimes if people have already had a buccal mucosa harvest before, they might ask for this. You can go back in and harvest the buccal mucosa again, but this is a little bit more humane as far as the discomfort goes for the patient. We've had a pretty good run with the buccal mucosa. We give them lidocaine, swish, and spit. If that still hurts, then we give them gabapentin, which seems to work pretty well too, take the edge off them for the first few days, but then they usually do pretty well. So rarely they'll get scarring or need another consultation. Maybe about 1 or 2 out of 100 will need that. So when you use skin, you got to be really careful about how you mature it. Oops. Because there was one that we went a little bit too aggressive on maturing it, meaning you take the backside and take all the fat and everything off of it. You go too much, it turns into a split thickness skin graft, and you get that, which is a contracture, which is a horrible outcome. So that's one of the things you got to be careful of. So I leave these things relatively thick. So the pathology you're going to get into when you open up. So there's a diverticulum that you see right there. So you're going to probably have to excise that for your first stage, but then, the top part here probably could keep that. That's actually decent plate right there. So that's the question, is what do you do? How much of the plate do you preserve? And then here's somebody that doesn't have any plate whatsoever. So you're going to have to make a plate by putting the buccal mucosa and stack it in here and suturing it in to the midline. So it creates a groove in there. You can have a nice plate when you do your first stage. So again, just suturing the buccal mucosa in, use 4 ovicrals, just put it laterally to the penile skin. Then we tack it down in the midline of the shaft, and there you go. You want to make this thing about 2.5 centimeters wide, at least in our experience. We have bolster sutures that we put on there because we do a dressing. I'll show you in a minute. So that's what it should look like, or what we think it should look like. And we try to bring it up into the glands as much as we possibly can. There's a little bit of native plate that remains right there. There's somebody who had a nice plate that we just kind of stacked it around the edge a little bit wide, but this person actually did pretty well eventually and create a nice urethrostomy down here. So that's going to be the first stage of the operation. We do an old fashioned. My residents were trying to talk me out of it to put back vacuum wound vac. Yeah, thank you very much. You can see how familiar I am with it actually. But basically, yeah, this is just going to be Xeroform gauze, cotton soaked in mineral oil and saline, and bolster sutures, and wrap that in a Coban. On for about 4 or 5 days, and bottom line is it's worked. So don't want to deviate from that. So what does it look like? This is skin. And you can see histologically, it looks like it's a pretty good take there as well too. We took a biopsy for a study that we did. We actually just kept this just to kind of show the continuity that it has. But really nice skin take there. And then you can see in the first, going to the second, getting ready for the second stage, you can see lengthwise, that's a good take. Buccal mucosa, I mean, no matter, it just seems to take quite well, no matter what you do to it. So that's one good thing, makes you look better than you are. And then you've got obviously down here, a little bit off center, but it's going to work for them okay when we go ahead and we separate between the skin and the buccal mucosa. So when we do the second stage, just make that incision right between the buccal mucosa and the skin. You raise this flap of this buccal mucosa and you close it. And you try and build that thing up as high as you can per the patient's wishes, what the patient wanted. So what about sexual function in this group? So this is a big issue, right? So this was also some work by Dan Stein around the same time, 2014. So if you look at normal adult controls with the IEF 15, that goes all the way up to 75. But if you're in the 60 range, that means you got pretty good erectile function as a whole. Erectile function, orgasmic function, sexual desire, it's all kind of packaged together. Preoperatively, look at the hypospadias patients before. They're starting at a lower level. So 39 is pretty much below average. Postoperatively, they may improve a little bit, but not significantly. They're still going to be maybe in the average range, but again, significantly, they didn't really turn the dial on any of this. Maybe a little bit better intercourse satisfaction. So what we're finding is there's just a lower level of sexual function across all domains in these patients, which is unfortunate. You can fix them, but they're still going to have issues. So again, something important to let them know in counseling that you're not going to fix their erectile. They still may have issues with erectile function, but you can straighten their penis out. You can do all these types of things, but you're still going to have some challenges. And I think so long as they know that and you can counsel them on that, I think they're better off for it. Same with ejaculation. This is unpublished data. This is some data that we collected, but I think it's pretty revealing that we use something like the MSHQ for the ejaculatory function domain. We decided to look at our stricture patients basically 25, which is good, which is going to be average ejaculatory function. Pediatric hypospadias failure patients, poor ejaculatory function. You fix them, they don't really, both groups didn't really move. Now, there may be a ceiling effect with this MSHQ, but again, you can see that there's an underlying ejaculatory issue. Even after you fix them, they have an open urethra, they still are having problems with ejaculation. The stricture patients, I think they kind of just top out from the ceiling effect of this particular questionnaire. Untreated adult hypospadias, I'd find guys that would come in, we sign them up with the IRB for the research study, distal mostly, hey, you want to just take this questionnaire? They all seem to look a little bit poor ejaculatory function. So something's going on with that. I'm not really quite sure what that is. It's the bulbous spongiosus muscles that aren't doing what they need to do or whatnot, but there is an ejaculatory function disorder. And these are guys that live their whole life with untreated or uncorrected hypospadias. So talking about that, I don't want to say uncorrected hypospadias, I want to say untreated hypospadias, right? I mean, it's thinking that, this is just people who chose, or their parents chose not to have anything done when they were children. But what is the functional and psychosocial impact of repair? Again, if you go back and look at the Swedish databases, there seems to be no difference between those who had them fixed versus those that don't. But again, the numbers are quite small, and we're only talking about distal hypospadias. Now, some recent studies have shown that LUTS and sexual dysfunction may be worse in those who have hypospadias. So the IPSS and SHIM scores are worse in those with untreated hypospadias as compared to controls. So not really quite sure why that would be. There's no evidence, especially there's no evidence of obstruction. Nicole Bush found the same thing, uncorrected or untreated distal hypospadias, urine spraying, penile curvature, painful sexual activity. All these things were evident in them, and it's really unclear why that would be. Does that mean if you fix their hypospadias, as we showed you in the previous slides, they're going to get better? Probably not. So I wouldn't use that as a way, at least from the ejaculatory function or the erectile function, to fix them. So again, this is very complicated, and you need to have a very serious conversation with these folks before you would come in for an adult coming to fix this. Concomitant lichen sclerosis in men with untreated hypospadias in the Cleveland Clinic experience was also found, where they found more lichen sclerosis in those who had untreated versus treated, but the numbers again are pretty small. So we see this as well too. So here is untreated hypospadias, and this guy also has a concealed penis. And of course, you shoot a rug on him and you get that. So probably more a function of the lichen sclerosis causing this, obviously, but in general, it's something to keep in mind that this is somebody that needs to be treated, obviously, but probably has nothing to do with this hypospadias. It might just be a coincidence. So future directions. So hyperbaric oxygen. Do you guys use hyperbaric oxygen for hypospadias? Yeah. We do it obviously for radiation cystitis, things like that, but there are some people that are using hyperbaric oxygen as adjunctive treatment for complex hypospadias repair. Now, the evidence is weak. Meta-analyses in the hyperbaric oxygen arm, there's less graft failure for a stage repair, less complications for single stage primary or redo. So it's safe. But I don't know if you guys understand exactly how many treatments you have to go. So Nicole Bush and Warren Snodgrass are saying 20 preoperative and 10 post-op. Have you ever seen what the tank looks like and how much time you have to spend in there? Drives my older folks crazy. I mean, it's a lot. So to have a child sit in there for that long period of time, I don't know how they do it. But it's obviously it's a heavy lift for children. It would be. But again, they're saying weak evidence that it may work. It may be something to consider. How about vasodilators in hyperbaric oxygen? Well, retrospective non-randomized studies in redo hypospadias cases, and that's going to be children and adults, anywhere from 5 months to 4 years follow-up. So not the greatest of evidence, but you look at group one, you throw the kitchen sink at them, you put on nitroglyceride, hyperbaric oxygen, local steroids, they had decent success. Group two, you take away the hyperbaric oxygen, less success. That could be patient selection, it's hard to say, but there may be something there as far as using all these things to help with the vasodilation of this. So HPO and vasodilators may improve outcomes in this cohort of men, but again, limitations on the study, but something to think about. We're trying to improve our outcomes here, So acceptable outcomes can be achieved using single or stage approach in adults with complex failed hypospadias repair. Patient selection is key, and buccal mucosa appears to be associated with better outcomes and fewer complaints or fewer complications with stage approach. You will get complaints if you have complications, no question about it. Patient-defined parameters of success should be established prior to surgery. Perineal urethrostomy should always be part of your discussion, even if it's hypospadias related or not. I think it's an operation that's underutilized in our field. So I want to thank my former residents, fellows, the people that contributed to a lot of this information that I have right now. A great group of people and doing some really nice things. And I want to show you this picture right here. So this is that VA I was talking about. So you see a cat there, right? What's the cat doing there? This is 3 o'clock in the morning. One of my residents took the picture for me. So we always talk about finding simple solutions or the most simple solution to complex problems. So the Hines VA had a rat problem, inside and outside. And they tried everything. They called exterminators, consultants. They did all these types of things. And someone finally came up with the thing, hey, there's some guy in Chicago that's got a group of feral cats. Let them loose inside and outside, and your problem will go away. Sure enough, these cats were walking around on the first floor of the VA. Rat problem gone within 3 months. It's pretty impressive, actually. What happened to the cats, I have no idea. Did they collect them back and give them this guy to go unleash in another place? I don't know, but I don't see him around Loyola at least. But I couldn't believe it when they told me this. But he's walking over to the VA and 3 o'clock in the morning got a picture. So they are there. I thank you for your time.